Hi folks, John Adamson, the Rehab and Documentation Guru. Sorry about the bad lighting. It's been a long day for me and I'm rather upset. Why am I upset? Because I believe that in general, the American doctor has lost the ability to make clinical decisions based on observation and manual assessment alone. So, I sent a patient to the hospital today. Guy had gained 17 pounds in a few days. He already was in CHF prior to. He's also got developing necrosis in his foot. He has gangrene on his foot, and when I went to see him today, the necrosis was worse. His weight gain had occurred. He had obvious jugular distension, and also he had a I'm blanking on the name. It's a not pressure interval. Yeah, I think it's pressure interval. The difference between systolic and diastolic, generally considered normal, is 40 millimeters of mercury, roughly. And there can be problems if you have a big gap or a small gap. And his gap was small. It was about 30. And usually about 25, if I remember right, is considered pretty dangerous clinical indication of active CHF. But he was at 30 at supine, so he was kind of chill. And he was definitely having a lot of shortness of breath, much more debilitated than last I saw him. The guy's failing. So I sent him to the ER for good reason. And I gave very specific instructions to his family member who was going to bring him with a note that I asked her to please pass on to the doctor. This is what's going on. But not only that, he was also developing a wound. He had the makings of a wound just barely starting in his coccyx area, and it was expanded today, so it was growing. And this, based on all his health factors, even though this was an acquired pressure ulcer, it clearly seems from his general health condition that this might be an unavoidable expansion of the wound, because they are doing everything they can to unweight it. Sometimes you get just the development of wounds that just occur on your body when you are failing in health, like late stage cardiac issues. And so anyway, I saw those factors. I spent time with him, sent him to the ER. What does the doctor do? Gives him some more Lasix and sends him home. And I had some choice words come through my mind at that point, because I guarantee. Well, here's another thing. Because I read the note, because I'm on Epic and I can read these notes. The doctor states that the patient's a poor historian. No, he's not. He's a little hard of hearing. You've got to give him a little extra time because of his hearing, but he's very coherent. He's a very smart dude. You just didn't spend your time listening to him. So you failed in your observational skills. You failed to look at the facts of what was going on. Significant weight gain, worsening wounds, worsening eschar on his foot. And you failed to admit him. And I've had this happen over and over again, where I ended up sending patients repeatedly to the hospital, and eventually somebody admitted them and it turned out they had something bad. What does it take? I'm sorry, now I'm just ranting. What does it take for a doctor to actually trust his clinical judgment rather than a one-time lab report or a one-time x-ray and go, you know what? This person's getting worse. Let's admit them just to make sure that we don't send them home and they get worse. I mean, you change their medicine significantly and you expect that to just take care of 17 pounds of weight gain in a few days when the guy was already highly edematous and he's got ascites now. Come on. So, why am I making this video? I have no idea. I'm just ranting at this point because I'm way overtired. But I just believe that doctors have lost the ability to assess. John Adamson, the Rehab and Documentation Guru. I better get going. Take care. Bye-bye.